ahead and get started. So this is part 2 to our kinetics series, and the first one was kind of a general overview of the antibiotics, and then some more information for our adult patient, and then today we'll specifically be talking about pediatric patients. So the objectives for this presentation are that by the end you'll be able to review the pediatric protocols for vancomycin and aminoglycosides, discuss the differences in pediatric protocols compared to the adult protocols, to understand pharmacokinetic principles related to the antimicrobials, and formulate plans for monitoring and adjusting regimens. Just like the first presentation, those of you who have been here for a while, this may, a lot of this is going to be just a review, but hopefully there will be some, a little bit of new information. But also feel free to ask questions so that information can be recorded and people can do that as well. And then at the end, we also will go over some cases like the last presentation. So some general tips for success for kinetics for our pediatric patient are that what patients are we using these in? These should be used for any patients less than 18 years of age at Arnold Palmer Medical Center. And then it's less than 16 years of age at the adult sites. So if there was a patient at Winnie Palmer who was 17, for example, that she would qualify for using the adult protocol. So for less than 18 at APMC, we're using the pediatric protocols. Another just general tip for success is we always want to look to see if there's previous regimens that patients receive for vancomycin or the aminoglycosides, because that can help us in determining a great starting point for the regimen that's being ordered. And that can be during the current hospitalization or during previous ones as well. Reading the progress notes can be really helpful to see what the physician's plan is, in particular for how long they plan to continue therapy. And then if there's any infectious disease progress notes, those are also going to be really useful for helping determine the plan for the patient. And then also another general tip is collaborating with the managing physicians. And certain units are even more looking for this collaboration, but certainly it can be useful in all of them. When you're unsure about whether you should go on higher end or lower end, or whether you should get a level now or wait, and that's not clear from the progress notes, call on those physicians, and they do appreciate that and being involved in the plan. And I always tell them, like, if we're going to not get a trough because I think they're going to discontinue it, we'll let them know, hey, we didn't order any troughs because it looks like it probably won't be needed past 48 hours unless the patient grew something that required the use, and they appreciate that. And it's also helpful for the residents because sometimes they think, oh, vancomycin, oh, there's no trough ordered, here, let me order one. And a lot of times we purposely have not ordered one when they first started the antibiotic. General documentation. We do want to write a consult note initiation, any level review, even if no adjustment is needed, so that the team knows that we've reviewed it and that no adjustment is necessary, or any change in therapy. For example, on rounds I may find that, hey, they're not really going to continue this past 48 hours likely, I'm going to cancel that trough. So I actually write a little note in there so that the pharmacist and the team reviewing afterwards knows why I canceled that trough. You can use the pharmacy pharmacokinetic consult notes. They have quite a few steps to go through with information you'll need to put in, or you can use just the progress note narrative and enter the information. And you can have a Word document saved with information you like and update it. And then we also have on the V drive note templates. And they're a little bit different. I don't know if anyone's had a chance to play with them. I added like drop downs to them, so you don't have to type information, but you can drop down and select the one, and then it auto-populates that. And then it also removes that kind of line underneath everything if you use that population. Has anyone used those notes? And if you ever have any feedback on those, certainly those are easily changeable, so let me know if there's things you want added or changed about those notes. So renal function assessment, because this is something we'll have to use for both vancomycin and aminoglycosides, I thought we'd start off with that beforehand. In pediatrics, creatinine clearance is determined using the Schwartz equation, and so that is here. In both the protocols you have what the K is, the constant depending on the patient's age and sex. I also want to bring to your attention that there is a bedside Schwartz equation that's a newer equation that's being used, and specifically our renal physicians like this equation. So if you're using their notes to see what creatinine clearance they are using, which can certainly be helpful, they may come up with a different number than you do or you see in Sunrise, and it's likely because they're using this equation. It is easier in the sense that you don't have to use a K, so there's no table. We still want to have our protocols using the Schwartz equation because that's what's been most validated. However, it's helpful to know what they may be using. And the numbers can be different. They can be a few off up till I've seen them up to 20 mLs per hour difference between the regular and the bedside. We do want to be careful using creatinine clearance in patients whose renal function is acutely or rapidly declining because there is a lag with serum creatinine changes. So if a patient's urine output has acutely dropped, they've been on vasopressors, we're really going to be careful using that creatinine clearance and probably be a little more conservative in our dosing or increase our monitoring for those patients. In our neonates, creatinine in the first 7 days is more reflective of the mother's creatinine, so that is not a good indication of the baby's urine output or renal function. So using urine output and for those patients is going to be more useful, and it's also just something that we can use for all of our patients we should be monitoring. Also note, if patients are on a diuretic, their renal function may improve better, may appear better than it actually is. So if they have a urine output of 1 mL per kilo per hour, but they're on a Lasix strip, well, it's probably not that good, and we need to be a little more cautious with dosing those patients. I also wanted to provide just a little bit of information about how you find information or data for urine output. If you go to flow sheets, you can see here, flow sheets, and then intake and output, and then you come over here and you select output. You can see urine output for the catheter, void not measured, mLs voided, and urine output. So some of these numbers might actually be in multiple places if they have a catheter, and then they took the catheter out, so you kind of have to look at multiple different rows. And then you can see here the totals, so you can see like the shift and the day, and then it also calculates mLs per kilo per hour. You just want to be careful what time frame that calculation is coming from, but this is a helpful place to look. In particular, some of our CF patients, they don't seem to monitor all of their urine output, so they may just mark void not measured, which means they know they went pee, but they don't know how much. So going through here, you can see how many of those occurred. Now, a little tip, instead of having to scroll through the entire thing trying to see if any numbers are entered, you can, if you right-click, so here, if you right-click on any of these, you can do show history, and it'll actually just show you all the values, so you don't have to scroll through. So let's start off talking about vancomycin. And in your packets, you'll find the protocols for vancomycin and aminoglycosides, so that if you want to check any of the information, because certainly I'm not going to go over all the details from those protocols, as well as the slide deck, and this is in those folders. So how do we start our vancomycin? Now that we've assessed their renal function and we're ready to start dosing? Well, we do have a few different tables for our patients. And the first is for our initial vancomycin doses for neonate less than or equal to 30 days in all NICU patients. So if the NICU patient is 45 days, we still use this table. Here we are going to start with their postmenstrual age, and then looking at the postnatal age. So the postmenstrual age is going to be their gestational age plus their chronological age. So if a neonate was born at 30 weeks, and now they're 14 days old, we're going to combine those. So 30 weeks plus their 14 days, so 2 weeks. So their postmenstrual age is 32 weeks. Does that make sense? Mm-hmm. And then you'd have to also look at their postnatal age. Yes, you also did account for that, their postmenstrual age, but you then look at this table here. So in this example, if they were 30 weeks gestation and they were 14 days old, we know their postmenstrual age is 32 weeks and they're 14 days. So everyone gets 15 days per kg, and then they would be Q12. Now what if in the next day they are 15 days old? Do you change the regimen? Probably not. You would want to see how long the patient's going to be on it, and if they're going to be on it for a while, you're likely going to get levels, and you can make adjustments from there, but you don't need to change just based on they have a change in age. Now, say they were 14 days and they had meningitis, for example, then I think that consideration can be given to the Q8, because tomorrow they're going to be Q8. In fact, they may only get 1 dose today, and by the time they get Q8, they may be 15 days old. So I think that's certainly nothing magical happens exactly on that midnight hour. So just kind of looking at that and thinking about the kind of infection, but you don't have to change when they reach the different age group, because as they're going to be continued on therapy, they should have levels. I did want to say on this one too, it's for neonates less than 30 days, and looking at the postmenstrual age. And I think a lot of times we think about that for our NICU patients, but if we have a pediatric patient come that's 7 days, 14 days old, it's helpful to look through their progress notes and see when they were born, because they may have been premature. And I don't think we always kind of think about that for our peds when they come to this side of the street, but they may be premature and may need adjustment in dosing. So if patients greater than 30 days, this is our pediatric tables where most of our doses probably come from. So we have different age groups, and we can see that 15 mg per kg Q6 is our standard for most. And then for 3 to 6, it's actually 20 mg per kg Q6, and then 12 and greater than 12, and it's 15 mg per kg Q8. So you may ask, what is different from the 3 to 6 year age group? Well, we actually we did a vancomycin study a number of years ago. It was like 7 years ago, and we looked at the doses required, and that age group in particular seemed to require higher doses. So that's why we went ahead and changed it on this protocol. So that's why the age group is a little bit different. But you can consider vancomycin 20 mg per kg for any age group who presents with meningitis or cystic fibrosis, because they are likely going to need higher doses. If a patient has renal dysfunction, then we're going to have to make some adjustments to our vancomycin dosing. And we kind of loosely defined it as a creatinine clearance less than 60 and or urine output less than 0.5 mL per kilo per hour. However, really looking at trends is important, because if a patient has a creatinine clearance of 120, and they've dropped down to 80, well, they probably are having some renal dysfunction, and it's worth looking at what dosing you're using. As I mentioned, you can look at the renal nephrology notes to see what their estimated creatinine clearance is. And in patients who have renal dysfunction, you can start with pulse dosing. And there is a vancomycin pulse dose identifier. And what this does is it allows that to stay there. So even though you put in a one-time dose they've given it, now when you pull up your list on Sunrise, they're not going to show up anymore unless you have this in there. So if you have your list built with this pulse dosing patient identifier, that patient will still be pulled up on your Kinetics Sunrise list. Certainly should still have them in the binder as well. It also will let the physician know that we're doing pulse dosing, and that's why they don't see an active order for vancomycin. When you order a trough, it's going to be kind of dependent on what you expect the dosing to be. So, for example, if you start it and you think, oh, they probably are going to need a Q12 regimen or Q18 regimen, then you can order a trough at that point to see what your level is. However, you have to be careful with your first one, because the first dose you're giving, that patient has no vancomycin. Now you've given them a dose, and we're looking for the trough to be, let's say, 15 micrograms per ml. So we could check it then. But then if that patient's 15 and we redose them, now we're starting with 15 micrograms per ml in that patient. So now we're going up that much higher. Does that make sense? You kind of already have that 15 there. So your next pulse dose, if you went out the same amount of time, or next trough, is likely going to be higher than your first one was if you did it the same interval. So it's something to keep in mind. You may have to, what I would suggest in these patients that you want to do a pulse dose in is give a dose, get a level, get a dose, give a level, and then if you find that they're pretty similar, or you do another one and you see that they're similar, then you can think about from then scheduling doses. And some patients with very poor renal function, talking about like HD patients, for example, they're going to continue with pulse dosing the entire time. But some patients might have a creatinine clearance of like 50, and you may see that, you know what, every 12 hours seems to really be right in range, and I don't need to do levels after each single dose. For these patients, certainly these are going to be really difficult to manage patients, and you gain experience after you've managed a number of them. So I would certainly recommend collaborating with other pharmacists that are there. If there are clinical pharmacists available for that area, talking with them. And then even with the physician, especially if nephrology is consulted, they like to be heavily involved with vancomycin dosing in their patients. And I didn't specifically put the tables up, but there are tables in the protocol for HD and CRRT, but it's 10 mg per kg dosing that you use, so it's a little bit different. So daily monitoring, we'll certainly want to continue to monitor the renal function. Serum creatinine should be monitored. However, we don't have the ability to order that without talking to the physician and getting an order from them for the pediatric protocol. In the adult protocol, you can actually do that per MAC, but for the pediatric one, it'll require a discussion with the physician to get a verbal order for that. Monitoring the BUN if available, and then the urine output, certainly something that we can monitor and should be monitoring every day. Clinical status, so how's the patient's doing? Are they deteriorating? Are they improving? Are they still febrile? And then any cultures. And I really think that we have a great opportunity to make interventions because we may see that the patient has cultures came back and they're on vancomycin, but hey, it's a Pseudomonas or it's an E. coli, and calling that physician and recommending that we discontinue vancomycin. It can also avoid us ordering unnecessary troughs. If we see that the cultures have already come back, we don't need vancomycin, we can recommend discontinue that and not order a trough in that patient. In general, we want to order troughs after initial trough at 3 to 4 doses. It's going to continue past the 48-hour rule out. And from my standpoint, I think that's the biggest area that we have to grow in our department, is trying to hold back on ordering so many troughs. I think a lot of times we see consults, we're on vancomycin, we order our trough, and then we're ready to go, because we don't want it to get dropped. We don't want them not to be monitored. But most of these patients are here for like a 48-hour rule out, and they don't really need a trough because it's likely going to be discontinued before we really be worrying about renal toxicity, for example. So if you see that they order cultures, we expect them to be finalized about 48 hours. So not ordering troughs until we know it's going to be continued is definitely appropriate. With a few exceptions. One, if they're having renal dysfunction already, then certainly we want to be more careful in monitoring those patients. And this probably doesn't apply to the cardiac patients because they like to monitor much more closely as well. So in those physicians usually like to have the plan discussed with them, so working with them to come up with a plan for monitoring. But in general, we don't need to order troughs unless we plan to continue past that 48-hour rule out. And then after that, we know we've gotten a good trough, and we're going to continue therapy, getting troughs every 5 to 7 days in patients with stable renal function is generally recommended, or every 2 to 3 days if they have unstable or changing renal function. Goal troughs. So these are very similar to the adult patients, with one exception. We do allow up to 10%, but we talked about with the adult patients that 10 is our minimum because you see increasing resistance with levels less than 10. However, those are really adult studies and hasn't been shown in pediatrics. So after discussion with our pediatric infectious disease physicians here, they felt it was appropriate to allow levels down to 9. So that's, I know, one kind of annoying difference between the two, but keeping that in mind, that we do allow 10% up or down for our ranges. One thing you may see, though, is that if you have a level of like 21 or 22, for example, that's certainly within that 10%, but I would also take a minute to kind of think about how long that therapy is going to be, and if they've only gotten 3 doses of vancomycin and you're already at 21, especially if they're a bigger patient, maybe they're going to take longer to get it to steady state, or you're going to be continuing for a really long time, and that may be kind of on the higher end. And a lot of times I'll make a small adjustment to their dose, and then I won't even recheck a level, because I assume they were there, I've made a small adjustment, maybe it's going to get them a little bit closer. That can certainly be a discussion with the physician, and generally these patients we consult, will have an ID consult if they're going to be continued for a significant period of time, and often they get a little uncomfortable if you're kind of hanging out at those levels above 20 as well. And then we do have on here that physicians may request a trough less than 10 if they had open chest prophylaxis and have poor renal function. I think that's something we've added to the protocol after finding out that those physicians didn't agree with kind of the higher established doses. For patients on dialysis, dialysis removes around 25 to 30% of vancomycin. You can see on the protocol it talks about low flux and high flux dialysis. Most of ours are going to be the high flux, so we estimate 25 to 30% of vancomycin to be removed. And there's a separate table here for the pre-dialysis dosing goals. Now, if any of you have managed patients in dialysis here, you know that often do them after, not before. However, there's some real benefits to doing them before. One, you can avoid having them to access the line again. So if you know your trough beforehand, you know that you need to give vancomycin during or right after dialysis, then they can have that ready and give it before they help block that line. The other benefit, and we kind of talked about this in the last, the women's lecture, is that you have that distribution phase right after dialysis, and so levels right after dialysis likely aren't accurate, so doing them before avoids that as well. If you do them after, you really should wait like 2 hours post dialysis, and I doubt that they're doing that consistently. And so you can see here that our pre-dialysis levels are going to be higher because we're going to expect some removal during dialysis. So dose adjustments. Well, the first thing we want to do is make sure the dose was drawn appropriately. So the last dose was actually given to vancomycin, what the time was between the dose and the level. And then after we decide that adjustments needed, we want to adjust either the dose or the frequency, but generally not both. We want to do one or the other. And we don't give more frequently than every 6 hours. And then as far as increases, doses less than 80 mg per kg per day, we don't want to increase by more than 50% at a time. And then doses greater than 80, we generally don't increase by 15 to 25%. That would be our max for how much we want to increase the dose. If the trough is very elevated, greater than 30, for example, then we probably should hold the vancomycin, check another level, and make sure that it's trending down and it's an appropriate range before we restart the vancomycin. And certainly we'd want to make an adjustment to our regimen as well, but you probably need to get another level to make sure that the level is decreasing before it reduces it. And then after you make adjustments, we want to recheck prior to the 4th dose. So let's talk about a patient case. So MH is an 8-year-old male, 20 kilos, admitted with rule-out meningitis. What would be his starting dose? Okay, and what would be your interval?
Q6.
Okay. So if you look at the protocol, 15 to 20. However, I would personally do 20 mg per kg IV Q6 for someone with meningitis. So that's 400 milligrams. So when would you get a level?
48 hours. It's just a rule out, so we'll check that.
Yeah, see if they're going to continue past their 48 hours. And these patients are almost always going to do a lumbar puncture, get CSF, and they're going to find out what it is often within the first day, but up to 48 hours, and then we can see whether we need to continue therapy. I know there's sometimes that you want to get it before that 4th dose, before you found out. Well, probably, if a patient's having renal dysfunction already, then you might want to be a little more aggressive in monitoring. Or if they have their meningitis is, they're very critically ill, they're on the vent from the meningitis, then maybe we want to make sure we got appropriate levels. But at that point, that's probably a good time to have a discussion with the physician or the ID physician about whether the troughs would be necessary just due to their illness. So a level is drawn before the 4th dose, and it's 11 micrograms per ml. What would you do? Increase the dose. So our goal is 15 to 20. We can use a ratio to find the new dose, assuming we have linear kinetics. So you can use either the dose or the daily dose, but if you're not going to be changing the interval, it's just easier usually just to do the actual dose. So 400 milligrams, and that gave us a level of 11. And we have our new dose with the desired trough. I just picked 17. It'll give us a 618 milligrams. However, you have to think about how much we're increasing the dose by. And I picked this one because I think it's a little challenging in that it's right at 80 mg per kg per day. And if you look at the protocol, it's greater than or less than. There's actually no equal to 80. So would we increase by 50 or would we increase by 15 and 25%? I think that's a gray area, like a lot of the kinetics is. So in this case, I kind of played around with the numbers and I thought, well, if we increase it to 500 milligrams Q6, it would be 25%. And maybe that's what I would do. However, that doesn't mean that that's the only answer, and certainly you could be justified going all the way up to 50% increases and all the way down to 15% as well. So now the RN reports the patient is turning red during the infusion. What do you think might be going on? Red man syndrome due to histamine release, so this is not an allergy. And the easiest thing we can do is slow the infusion rate, so greater than 1 gram per hour. We can consider administering via central line if the patient has a central line, so recommending that they use that line for the administration of vancomycin, or schedule or order PRN diphenhydramine, recommending that to the physician. Often I see that these patients will, we slow the infusion rate, they'll do PRN diphenhydramine and they don't actually require it, but certainly if they seem to be requiring it, scheduling it can be a way that the nurse doesn't unintentionally forget it, and by the time you're doing it as needed, they likely have already started having that reaction, so if they do that, scheduling it might be appropriate. So what are some other adverse effects of vancomycin that we should be monitoring for or consider?
Renal?
Renal, yeah, that's a big thing. Nephrotoxicity. It specifically can cause interstitial nephritis, and it's associated with prolonged elevated troughs, duration greater than 7 days, and concomitant nephrotoxins. And it really was seen when vancomycin was first on the market, and it's seen a lot less now, but certainly there's still a big fear of nephrotoxicity from vancomycin. There also, vancomycin can rarely cause rash, and there are reports of ototoxicity as well. So let's move on to talking about kinetics. Were there any questions about vancomycin? Okay. So we'll talk in general about pharmacokinetics, and that'll help kind of segue us into the aminoglycosides. Okay, so volume and distribution. So I thought that we'd kind of just go through and talk about these pharmacokinetic parameters in general, so that when we're looking at the equations, we kind of understand what these numbers mean, and when they're different than what we expect, what that actually might mean for the patient. So what is the volume and distribution? Well, it's kind of the volume required to account for all of the drug in the body. It's where the drug is going in the body. So a large volume distribution indicates that the drug is probably lipophilic, so it's moving into all the different tissues and fat in the body. A medication that has a small volume distribution is probably more hydrophilic and is more in the body tissues and fluids. So it's a smaller volume that it's in. This actually directly affects our target concentrations. So if we have a dose here, 100 milligrams, divided by 1 liter compared to 10 liters is going to affect our drug concentration. So the bigger our volume is, the smaller our drug concentration will be for the same dose. Does that make sense? So now that we understand kind of how it works for the drug, it's also helpful to understand why patients might have different volumes of distribution for the same medication. And that's when we're talking about population kinetics versus our patient kinetics. Well, the BD can actually change based on the patient's clinical status. If a patient has low albumin, you're going to have less binding of the drug, and you might have a larger distribution of the hydrophilic drugs. Also, you might have a larger distribution in critically ill patients or patients who have ascites or cirrhosis. Patients who may have a smaller distribution of those hydrophilic drugs are those who come in with who come in emaciated, and those patients you might actually see a smaller volume distribution for hydrophilic medications. Lipophilic medications you may not see as much of a difference because they're so widely distributed throughout the body already. So looking here, you can kind of see how the drug would distribute throughout the body. The distribution phase is the time that it takes for the BD to be filled. So here, if we're giving a medication, you see during the IV bolus dose, it's going up the concentration. And then you're going to have distribution phase into the tissues. So while it's in the blood, your concentration is going to be 1, but while the drug distributes out the body, that concentration is going to decrease. And we, if you remember when we made changes to the protocols a little over a year ago, I think now, we were first looking at the C peak 30-minute, and so what we were doing there is we were trying to look for this concentration here. But now we've made adjustments to the protocol, and now we use the C max, and that's this concentration. So that's why we have higher target peaks now, is because we're looking for this concentration instead of this one. What that means clinically, it's kind of thought that the C peak or C max is more of a theoretical concentration, and that we're not really there long, like it's distributing throughout the body as it's infusing. However, there's more studies in CF that were using that target for their goals, so it made sense for us to kind of use that. And also the calculations are a little bit easier if you use C max, but certainly we're just adjusting our C max based on which one of these we're looking at. So equilibrium is maintained between the central and peripheral compartment. So as we're giving the drug, the central kind of being the serum, and it's moving into the periphery, and that's obviously an equilibrium going back and forth, and then it's eliminated throughout the body. So the next pharmacokinetic parameter that we talk about is elimination rate constant and half-life. So the KE is a fraction of drug removed per unit of time. And this represents the slope of a plasma concentration versus time graph. I'll show you that in a minute. But a higher KE represents faster clearance, and our KE is used to then estimate our half-life. It's highly patient-specific. However, population parameters are going to guide our empiric therapy before we get levels. And we can actually calculate KE with 2 plasma levels. So you can see here, our KE is going to be this slope here. That's what we're looking at when we're looking at KE. So when we have a concentration and a second concentration, no dose in between, so we're just looking at the elimination of the drug in the body, KE is going to be this slope. So a higher KE is going to indicate a steeper slope and faster clearance, elimination of the medication. The half-life is going to be the time for the plasma concentration to decrease by half. So we're going from 100% to 50% to 25% to 12.5%, so it's going to kind of taper off with our half-life. And it's associated with the rate of elimination and can be estimated with a KE. So a faster KE is going to mean a shorter half-life and more frequent dosing required. And then the opposite, a slower KE would mean a longer half-life and less frequent dosing required. And certainly it's a critical component when we look at trying to achieve target concentrations. Especially with time-dependent antibiotics like our beta-lactams, if we're having a short half-life, it's going to be falling below our goal level for those patients. So steady state is going to be the rate of drug into the body when that equals the rate eliminated from the body. It occurs after accumulation with successive multiple doses, and the peak and trough levels are the same for each dose. The levels will depend on the KE, is volume distribution, and the dosing interval. And the time to reach steady state is generally 4 to 5 half-lives. So you can see that here. And the light blue is a shorter half-life, and the dark blue is a longer half-life. And we're looking for when the peaks are the same and the troughs are the same from each dose. You can see it's a little bit longer, the longer half-life. Each of these are going to represent a dose. So next I'd like to move to talk specifically about aminoglycosides, and we'll be applying some of those pharmacokinetic parameters that we spoke about. So for the aminoglycosides, we're really trying to achieve a pharmacokinetic target of a Cmax greater than the MIC of 8 to 10. So that is, here you can see that this is a concentration of the drug. So as we're infusing, we're here, and then as we're distributing in the body and then starting to eliminate, the concentration goes down. Our minimum inhibitory concentration is going to be the concentration in the body that doesn't allow the bacteria to grow anymore and inhibits its growth. And so we want to get a concentration that's 8 to 10 times higher than that minimum inhibitory concentration. So that is our target for these for aminoglycosides. And we have two different dosing strategies. We have traditional or conventional dosing, and that's intermittent doses, generally every 8 hours. And then we have our extended interval, or once daily. And these are large daily doses with adjustments based on a 10-hour or trough levels. When we do the extended interval, we're achieving higher Cmaxes because we're giving much bigger doses, so we're going to get much higher concentrations. And we can lower the risk of nephrotoxicity as well, because we're going to have we're going to be to lower troughs, because we're only doing every 24-hour dosing. So the next kind of thing we need to think about when dosing our patients is what dosing rate we're going to use. Well, for extended interval, you actually just use the patient's actual body weight. But for conventional dosing, you need to consider whether the patient is obese or not. For patients less than 2, we use the actual body weight for all of those patients. For patients who are 2 and greater, we need to verify the BMI and sunrise. And then there's a table in the protocol that will show you which patients fall above the 90 or fall at or above the 95th percentile for the BMI. And then we want to use adjustments for those patients. For the extended interval dosing, that's going to be our default strategy for all patients greater than 1 month. And there are a few exclusions. Those patients who are in the NICU, who have renal impairment or on dialysis, because it's an entirely different dosing strategy altogether, who have hemodynamic instability or are critically ill. The reason for that is those patients may have very altered volumes of distribution, and you worry about getting to appropriate concentrations in those patients. Those who are getting enterococcal synergy dosing, or those who are being treated for a mycobacterial infection. And that's actually a new section that's being added to the protocol, but I'll show you a little bit about it now. So first, the extended interval dosing. There's a lot of tables in the aminoglycoside protocol for different dosing regimens for patients, but I put a few up here. And the first is patients who are non-CF, who are greater than 1 month, and who are receiving the extended interval. So these patients, those who have a UTI or pyelonephritis are going to receive 5 mg per kg, and those who have other infections, 7 to 7.5 mg per kg. And then synergy dosing is going to be 3 mg per kg. And you can use synergy dosing for streptococcus or staphylococcal endocarditis. And the adult protocol is actually being changed to encourage the use of 3 mg per kg Q24 instead of 1 mg per kg Q8. With the same kind of theories of why we do extended interval for our other doses, and that you're getting higher peaks, reducing the risk of nephrotoxicity. And we also have amikacin dosing. And then for our cystic fibrosis patients, they're going to have higher doses. So for gentamicin, tobramycin, 10 to 12 mg per kg. And we'll kind of talk about why those patients require higher doses. The target levels, our Cmax and our Cmins that we're aiming for, are all found within tables in the protocol, and there are numerous of them. So making sure that you're using the right age, and that less than 30 days, greater than 30 days, cystic fibrosis versus non-cystic fibrosis, and then your kind of infection as well, are all going to help lead you to the recommended Cmax and C peaks and Cmins. It's also, 10% is generally acceptable as well. Conventional dosing, there are numerous tables, we talked about all of that. And then mycobacterial infection dosing, so this is a new section being added to the adult and the pediatric protocols. And in these patients, amikacin is the preferred agent, and it's used in combination with other agents when patients have mycobacterial infection that is resistant to other antibiotics, or when there's a high burden of the disease, and they may be using multiple agents. So in these cases, they can do, amikacin is the preferred agent, so they really shouldn't be using tobramycin or gentamicin for mycobacterial infections. And the dose can be either 3 times weekly, or it can be daily. And these patients often receive therapy for a minimum of weeks. So it's helpful to do every 3 times weekly dosing because of that. And you should have higher peaks because you're using higher doses. And there's some days you're not giving it at all, so hopefully that reduces your risk of nephrotoxicity as well. So there is also going to be information about how you monitor levels for these patients. For the adult protocol, it's going to be recommended that it's 3 times weekly for all patients unless the physician specifically wants daily. With the pediatric protocol, we have both as options. And I did talk to our physicians here, and they often do start with daily amikacin, and then as the patient improves, they move to 3 times a week. And then you can see here our target serum concentrations. So if you're watching the video, hopefully this is in there. In our current protocol and within the goal ranges, there's actually a line for mycobacterial, but those levels are wrong. Going through this, I found, look at those levels, they're not the same as these, so don't choose those. But hopefully they will be gone if you're watching the video, and that this will be this new section. Monitoring. These patients, just like our patients on vancomycin, we're going to monitor serum creatinine, and in general, we want to monitor at least every 7 days. BUN, urine output. Levels, just as in vancomycin, are not needed for short courses. When we're using for gram-positive synergy, we're using much lower doses, so really only troughs are needed in those patients to making sure that we're not going to cause nephrotoxicity. For extended interval, usually at 2 to 3 days, we'll get levels 2 and 6 hours post-dose. And the reason we do 2 and 6 versus 2 in a trough, for example, is because often the trough is undetectable or less than a certain number, but we want to have an actual concentration so that we can calculate that KD. Conventional, we want to get levels generally on the 3rd or 4th dose, so patients are at steady state. And then in those patients, we want to do a trough and a peak. Now, in some NICU patients, they may require daily dosing of aminoglycosides, but that's not extended interval. Due to their renal function, that's actually conventional, but in their case, that correlates to every 24 hours. And then follow-up troughs every 7 days if stable, and they're going to be continuing therapy. So let's talk about a patient case. So we have a 13-year-old male with cystic fibrosis exacerbation. He's 44.3 kilograms, and there's a consult for tobramycin. So what else do you need to know about this patient?
If they've been on it before, and
Yeah.
what the dose was.
Great. 4. Anything else? Renal function? Right. Okay, so in this patient, they have a serum creatinine of 0.61 milligrams per deciliter, and they just came in, so we don't have anything reported for urine output yet. I also want to look at their cultures, what other antibiotics are on, and past regimens. And this patient, I just pulled from Sunrise, so, and this patient was here 7 months ago, and they were receiving tobramycin 500 milligrams IV Q24 hours. So, looking at our dosing schedule and knowing what they're on in the past, what would you recommend to start this patient out on? Yeah, so they were on tobramycin 500 milligrams in the past. You think that would be a reasonable thing to start at?
Mm-hmm.
Yeah. And I think a protocol says if they received aminoglycosides in the last 6 months, so this patient received 7 months, but if you look at our dosing, they fall right there, as right in between that. So that's a great dose to start with. So when would you draw levels for this patient?
Do the first dose, do the 2 and 6 hours?
Well, they for the CF patients, it's after 3 days of therapy is the standard. So 2 and 6 hour levels. And what would be our goal levels for this patient? I know there's a number of tables.
30 to 40?
35 to 40, and a trough less than 1. So any questions about him? We'll talk about him more after the lecture as well. So this patient is a cystic fibrosis patient, and that probably is the most common patient we see receiving aminoglycosides now. So I want to touch a little bit about these patients and how they're managed is different. So what is CF? It's a genetic disorder that causes dysfunctional CF-conducted transmembrane regulator proteins. So what does that mean as far as using antibiotics in pulmonary infections? Well, it causes thick mucus throughout the pulmonary system, and that leads to recurrent bacterial infections. And these chronic infections and recurrent infections are going to lead to inflammation within the airways. This could lead to destruction of the bronchioles and progressive loss of pulmonary function. So that's what we're trying to avoid in these patients. The guidelines for CF recommend 2 IV anti-pseudomonal antibiotics, and this was recommended to reduce development of resistance. There were some studies that looked at whether you needed 1 or 2, and they saw similar efficacy for resolution of the infection. However, when they used only 1 antibiotic, there was a slight trend towards increased resistance, and so it's still recommended to use 2 antibiotics. A beta-lactam and aminoglycoside is the most common combination agent used for cystic fibrosis. You can use fluoroquinolone as another option with one of these agents, but usually beta-lactam, such as cefepime or zosyn, and then an aminoglycoside. There are limited studies looking at gentamicin, so it's still recommended that amikacin and tobramycin are the preferred aminoglycosides used. And there's actually some increased some increased nephrotoxicity seen with gentamicin. That's part of the reason why it's still recommended that amikacin and tobramycin be used preferentially. CF patients have a higher volume distribution and a shorter half-life. So what does that mean for dosing? Well, we talked about when you have that higher volume distribution, you need a higher dose to achieve that same concentration. So that's why we're using higher doses in CF patients. It's because they have a higher volume distribution. And then, and for these patients, we can use once, twice, or 3 times daily dosing. There are limited studies that use Q24-hour dosing for CF patients. Well, for any pediatric patients, really. But those studies did find that there was success when using that dosing regimen. In these patients, you may see that they're on other antibiotics, and I just kind of want to touch on why, because it may be for a reason that you wouldn't be thinking of. You may see, oh, why are they on one of these antibiotics? Do they need to be on tobramycin if they're on inhaled tobramycin, for example? But it's been found that scheduled antibiotics may decrease inflammation within the airways and reduce exacerbations. This is specifically found in patients 6 years and greater. It's not that it wasn't found in patients less than 6, it's that there haven't been good studies. So all these recommendations from the cystic fibrosis group are all for patients 6 and above. And the first thing recommended is azithromycin 3 times weekly. And they found substantial benefit with high certainty for patients with Pseudomonas that's persistently in the lungs. In regard to the high certainty, low certainty, moderate certainty, the guidelines use those just to indicate for the recommendations how certain they are that it's really going to be a benefit and how much of a benefit it will be. So for azithromycin, there's substantial benefit, and they're pretty certain it's going to be useful. So you'll probably see most of these patients on azithromycin 3 times weekly. And it's not because they have mycobacterial infection necessarily, they may have one, but it's because it actually decreases inflammation in the airways, particularly for those who have pseudomonal infections, because those patients are probably going to have more inflammation in their lungs. You can consider it for patients who don't have recurrent pseudomonal infections as well. There's just less studies showing that it's efficacious for them. Patients may be on inhaled tobramycin and aztreonam, and this is found to be substantial benefit with high certainty for patients with moderate to severe disease, and then moderate benefit with moderate certainty for patients with mild disease. And this isn't for treatment of pulmonary infections or CF exacerbations. This is for maintenance therapy. So if a patient comes in here to receive IV antibiotics, these shouldn't be used as one of our antibiotics. So these are just to decrease inflammation and are used chronically, but not for that exacerbation. Other inhaled antibiotics have been, there's been small studies, ceftazidime, colistin, gentamicin. However, there's insufficient evidence to support those recommendations for those agents. Using oral chronic anti-staphylococcal antibiotics, the guidelines say there's insufficient evidence to recommend for patients with Staph aureus. and it's not recommended at all for those without Staph aureus. So at this point, they're not sure whether those chronic, daily administration of oral anti-staphylococcal agents is of any benefit for these patients. So in summary, pediatric patients, the pediatric protocols contain a lot of information, so using those kind of sifting through, trying to find where your patient falls in the tables is going to be of benefit. The use of kinetic equations is often needed for the pediatric patient receiving aminoglycosides, and the patient with cystic fibrosis has altered pharmacokinetic and dynamic properties that require using different dosing strategies. Are there any questions?
Sometimes the CF patients, like, there's frequently, well, I don't know how frequently, but I get kind of thrown off when I see like the Q12 regimens. Like they may have been on a Q12 regimen in the past, but then they meet all the criteria and you would guess that I would be doing Q24 dosing.
Yeah.
And so is there like some sort of logic behind who gets Q12 versus Q24?
That's a great question. So, and the guidelines do touch on that because Q8, Q12 regimens have been more widely studied, and so that's one potential benefit. But you also, if you have a patient who's on Q24, for example, and you find that their level is low or even undetectable very quickly, and that's one of the cases we'll talk about, maybe within 6 hours they have an undetectable level, you have to worry about then how much of that dosing interval that they don't have any antibiotic in. Aminoglycosides do have a post-antibiotic effect, so that means even after your concentration is below what would be therapeutic, you still see benefit and decrease of antibiotic or of bacterial growth. So there is some thought that you would have the post-antibiotic effect that's after you have that concentration drop below anyhow. But there's a concern, theoretical I suppose, that if you have a long period without any antibiotic, that there may be, those patients may be worse. Now, I don't think there's any great, I can't tell you like a certain time, like, 8 hours, then you would do this versus that. I definitely see a lot of cystic fibrosis patients that they do use Q12 on here. And so I often look back on what they were on, and if they're on Q12, then I usually do continue them on Q12. But really those patients are probably going to be a question with the prescriber if you want to change it. Because there's theoretical benefits to using Q24 on cystic fibrosis patients as well. Particularly if they are getting out of the hospital a lot. A lot of those patients are on passes and stuff, so there's other benefits to Q24 as well.
And then glycoside protocol, are we supposed, if we don't have a serum creatinine, are we supposed to call to get an order for it like the Vanco as well?
Yes, yeah. You should get a call for it, not put it in automatically. So we'll stop the video. Do you have calculators? Yeah. Yay, okay. These are the 2 case samples. You need one of each too.
Or are these different than?
Oh yes, so I put some that we just had in the kinetics folder for all of these, just so that you know what the cases if you want to look at. But I made, like they had answers and everything, but I made new cases for us to talk about now.
Oh.